Good day, friends, and a warm welcome to season 3.0 of 4D, episode 7. 4D, as you all know, is detailed discussion and dialogue in diabetes. And as we have discussed in detail so many times, we need to keep on discussing. We need to keep on having a dialogue because we need to keep on learning. We need to keep on sharing from each other. Let's welcome 3 experts today who will take us through the nuances of diabetes and metabolic syndrome screening, diagnosis and monitoring. So a warm welcome to Dr. Pankaj Patil. Warm welcome, Dr. Pankaj. Dr. Pankaj is an interventional and consulting cardiologist with more than a decade of experience, and he works at Kalyan and Thane in Maharashtra. And he specializes not only in the most complex of angioplasties and interventions, but also in public health, in primary care, and in preventive cardiology. So warm welcome, Dr. Patil. We'd also like to welcome Dr. Darshana Sudeep Thakur. Dr. Darshana, warm welcome.
Hello, sir. Thank you, sir.
Thank you so much. Madam is a consultant endocrinologist with gold medal and distinctions from KEM and Nair Hospital. Dr. Darshana, there's a question coming from Dr. Ameya Joshi in Bombay. And he says, Madam, did you leave any medal or any distinction for the poor little boys in your class, or you took all the medals and distinctions?
That is a nice question, sir. But yeah, my boys in my class were equally good, I guess. But there was a hint of luck with me, I guess. That helped me get to the point.
So it's nice that we bond with the best, because there is this saying, this ancient saying from Haryana, which says that if you bond with the goldsmiths, then you get gold. And if you bond with the ironsmiths, then you get iron. So today is a gold day for us. So Pankaj, what do you think? We've hit jackpot, we have hit gold pot. We'll also become golden then. We'd also like to welcome Dr. Nayanesh Chavan. Dr. Nayanesh, warm welcome, sir.
Good evening, sir. Thanks.
Dr. Nayanesh is a consultant nephrologist and transplant physician. He works in both both conventional nephrology and transplantation. And he is associate professor at the SMBT Medical College, and he works in Nasik. Warm welcome, sir.
Thank you, sir. Yes.
Dr. Nayanesh, it's said that our NAMs or our eyes are a window to our health and our disease. Do you think that's true? Can you make out the health of a person from his or her eyes?
Yeah, sure, sir. Why not? When we look in the inside the eyes of a person, okay, we can feel its pain, his suffering, as well as the joy of recovering from an illness. Okay, definitely the eye mirrors the person's health, psychological as well as physical, sir. I fully agree.
And when we join MBBS, and we welcome everyone who is logged in today, we have physicians logged in from the entire country. So when we join MBBS, we reach second year, third year, and they take us to the wards. How do they begin teaching us the general physical examination? Let's look at it from an eye point of view. Anything relevant from what you learned in third year MBBS to what you're doing now as a transplant physician or as a nephrologist?
Sir, whenever the patient comes now, so it is very important that personal touch to the patient, sir. When nowadays what is happening with clinical examination, taking the backstage, so nowadays touch has become linked with the patient. We are more of investigations oriented. When I was taken for the third year round, I remember my professors, they were very keen that you maintain the touch with the patient, that we get an emotional bond, patient and doctor trust build up. And it is said that with a physician's touch only, most of the complaints of the patients will vanish. So definitely, sir, it is very important that we should maintain a touch with the patient. That is very important for me.
Yeah, and you're right, because of multiple reasons, and then precipitated by the COVID pandemic, we kind of developed, and the English word is haphiphobia. There is a word also for phobia of touch, HAPHE, phobia. So we all developed that, and then we are trying to come out of it, I guess, as the medical fraternity. So thanks, Dr. Nayanesh. Dr. Pankaj, just like you can look into a person's eyes, you can look for pallor, you can look for icterus, and you can also see whether the person is happy or not. Does the heart make you happy? Does the heart make you sad, or is it a target of happiness and sorrow?
Yes, definitely. As you see, saw about the eyes, definitely, if your heart is okay, your heart is beating properly, then definitely it reflects your outer scenario. If your heart is okay, then definitely it will reflect on your behavior. It will reflect on your activities, and definitely it will reflect on your patients also, how you behave with your patients. So definitely, as the doctor per se, at the heart of a doctor, heart of the patients, definitely it will reflect on their external behavior and their all the things which we see from the external appearance definitely depends upon the heart condition.
This is so nice, and I'm grateful to both of you for having given this such a human touch. And again, speaking to everyone, our talk shows, our 4D shows are not scripted. But you see Dr. Chavan talking about looking into the eyes, feeling the way the other person feels, the patient. And then you see Dr. Pankaj talking about it's not only the patient's happiness or health, it is ours as well. Our heart also contributes to the interaction between the patient and the physician. Dr. Darshana, is that right from an endocrine perspective? What does the word hormone mean to you? What does the word pheromone mean to you? And do you think that actually hormones and pheromones that the doctor releases will have an impact on the outcomes of a patient?
So I think we have the longest contact with the patients as diabetologist because diabetes is a chronic disease. So patients keep on coming to us, and over a period of time, we become from the diabetologist to actually their family doctor only. The contact and the trust what we have with our patient before going to any other specialty, the patient will come back to us and ask if for this problem, where should I be going? So I think we are that contact point for the patient, and that comfort should always be established between us and the patient. As far as the hormone is concerned, nowadays I think that is one of the most used and the abused word, I guess. Everyone is using that, this and that aspect. So for me, hormone is very important word. We being endocrinologist, and I think maximum things in from the point of view of hormone we can fix nowadays with a lot of new things coming up. So yes, and the pheromones, I think it is the chemistry between the two. Maybe we and the patients and the other consultants, their family members, everyone, and that needs to be established because there is a psychological or a psychiatric component to diabetic management, and if we hit that, I think we get the best of the results from our treatment. That is what I keep.
So, thank you, madam. And what all our experts are saying, and I'm sure what all of us believe, is that there is a human angle to medicine. That human angle, unfortunately, is becoming weaker and weaker due to maybe some factors within our control, but most of the factors are beyond our control. But still, we can make a difference. And even if you make a difference, one person at a time, one OPT consultation at a time, it will actually have an impact on the society as a whole. Dr. Nanish, let's come back to third year. Let's come back to MBBS. And our topic for today is actually investigations. How we can use the newer investigations to understand what metabolic syndrome is and to predict the future. But maybe the first test that we learn is hemoglobin and then a urine routine. So let's take a nephrology perspective for hemoglobin. Is it good? Is it bad? And then we'll ask Dr. Pankaj and Dr. Darshana the same question. So let's begin with the basics.
So, of course, maintaining the hemoglobin in the normal level is must. As far as the nephrology perspective is concerned, the kidney secretes the hormone erythropoietin, and that plays an important role in stimulation of hematopoiesis. So the hemoglobin level is maintained in the normal range in the normal patients, but in CKD this condition with cancer, isn't it? So the hemoglobin continues to fall, and the falling hemoglobin further worsens patient's clinical condition. He starts getting generalized weakness, decreased appetite, as well as breathlessness. So in CKD, in nephrology perspective, maintaining the normal hemoglobin level is utmost important by supplements like iron, B12, folic acid, and whenever necessary, the erythropoietin. As you said, that higher level also is not good. That is true for our patients in CKD. We usually don't target beyond 11 gram per deciliter hemoglobin. Okay, so our target is around 10.5 to 11 using the external supplements. And second thing about the urine lutein, I think this is our most neglected test, but it serves very important role in diagnosing our patients. Usually, what my observation in the clinical practice is that the technician will see the urine, will do the analysis of urine put in a microscopy, and usually the detection of the proteinuria as well as active sediments like hematuria, RBCs are usually missed, and the technician's interpretation also is not up to the mark what we expect as an nephrologist, and this makes huge difference for us for diagnosing, because proteinuria is a very important prognostic factor kidney wise, in the angle of kidneys as well as cardiac also, as well as diagnosing the early CKD, detection of early CKD. Many times the renal parameters are normal, but it is the first sign which appears in the patient is the proteinuria, trace or 1 plus. So, urine routine microscopy has to be taken with utmost seriousness, and I believe nephrologists should make a habit to see the urine routine slide also. Now very few nephrologists nowadays take that path. They will go and prepare the slide and do the test themselves. But it is good thing to do it. We should not rely on the technicians, and we should not miss the proteinuria, which would detect it as early as possible. So urine routine micron hemoglobin, both are very important tests for us. Many times the falling hemoglobin in a patient is because patient, whenever he goes to a local registered medical practitioner, general practitioner, they will check how much is your hemoglobin. Let's see. And the CKD patient presents with hemoglobin of 5 and 6. For us, the kidney patients, hemoglobin detection is very important. No doubt about that.
So thank you for highlighting these. So what we learn is that, first of all, the simplest of tests like a hemoglobin or urine routine are equally important, equally relevant in today's practice. When you see from a CKD or metabolic syndrome perspective, of course, we all know the definition of polycythemia, but in chronic kidney disease, the definition changes. So the term that we use in endocrinology is a Goldilocks metabolite. Goldilocks metabolite or Goldilocks hormone means like insulin, Dr. Darshana. If you give too much, then you get in trouble. If you give even 1 unit less, then also you get in trouble. So hemoglobin should be just right. It should be just perfect, 10.5. Another thing I realized while Dr. Chavan was speaking is that we need to reach out to our nephrology and medicine colleagues in the Himalayas. Maybe there is a different cutoff for Ladakh, maybe a different cutoff for Arunachal and Sikkim, which we are not aware of. So perhaps our colleagues in the armed forces might want to work on this and see what the target, that Goldilocks target, is for hemoglobin in CKD. The other thing Dr. Chavan highlighted was the rate of fall of hemoglobin. Suddenly hemoglobin falls down. Now in pregnancy, in obstetric medicine, you will have a different approach. In CKD also, you will have a different approach. But and we'll talk about albuminuria later. But Dr. Pankaj, let's just focus on hemoglobin. We talk about the 4 pillars of therapy in heart failure. We talk about medical optimization for chronic stable angina. Do any of the Western guidelines talk about hemoglobin, or is it just a poor man's metabolite? Your message for Indian cardiologists and Indian physicians, please.
Exactly the thing which you are talking, sir, was exactly, I think, 5 to 6 years back when hemoglobin was being neglected from cardiology point of view. But recently, if you see, especially if you ask about the patient of heart failure, then definitely a patient with a low hemoglobin or anemia, mostly because of iron deficiency, are more prone, especially for the worsening of heart failure. And these patients do have repeated episodes for hospitalization for heart failure, and they have poor recovery, and there is high morbidity and mortality in these sorts of patients. So definitely low hemoglobin or anemia in these sorts of patients in a non-heart failure patients is a poor marker or poor prognostic factor for them. Apart from them, anemia per se is again hemoglobin is a carrier of oxygen, so definitely it's a worsening for the ischemia, myocardial ischemia. There are certain causes of anjana which are precipitated by low hemoglobin. And again, as discussed by Dr. Nainet Chavan, that as low is very dangerous and high is also very dangerous. We can see many patients having hemoglobinopathies, may have secondary polycythemia. Some certain smokers, these patients do have episodes of strokes or episodes of MI, especially in the younger age. I have seen patients in under age of 20 years also who are having history of polycythemia, mostly secondary because of smoking, and they have suffered from myocardial infarction. So definitely, hemoglobin per se is very, very important. Nowadays, it has been very, very clearly highlighted in the diagnostic approach and the treatment approach of heart failure and the CAD patients also. So I personally do ask each and every patient when they are following up to do the CBC, simple CBC, and accordingly, definitely, if there is any efficiency, then we have to correct it.
Thank you so much. And we have a comment from Panchkula in Haryana, Dr. Suneet Verma, who is a physician. He thanks you, and he especially thanks Dr. Chavan and Dr. Patil for highlighting the fact that you have to be in the right range. Too much is also bad, too little is equally bad. And hematocrit is something that the physician, it actually hurts the physician. In dengue fever, in dengue hemorrhagic, it is the hematocrit that you will keep on monitoring to see whether your patient is getting into trouble or not. Dr. Darshana, from an endocrine perspective, any things that come to your mind, any diseases in children, any autoimmune diseases where we might have low hemoglobin, where we might have a high hematocrit that we caused because of endocrine, misadventure by over-treating, and what should the physician be aware of?
So I think from a endocrine point of view, important is drug-induced anemia also. I mean, for the agents like pioglitazone, we have to look for the anemia part as well. Second part is hemoglobin HbA1c interpretation will also change with anemia. And as far as the children are concerned, I think celiac disease is one which also indicate the nutritional status of the patient can result in the low hemoglobin or anemia. As far as the urine routine is concerned, I think most of the points are covered by Dr. Chavan and Dr. Patil. But one thing which I want to tell is that if there is other factors like the casts are present or altered RBCs are present, microscopic hematuria is present, then it can indicate that there is some other reason to the nephropathy than the diabetic kidney disease. So that is a very important point for us, because at that point we have to definitely refer to our nephrology colleague so that they can manage this problem well. One more pointer is that as far as the hemoglobin and the total RBC count, the platelet count and the WBC count is concerned, there can be all the pancytopenia in cases of liver diseases. So cirrhosis of liver or NASH cirrhosis is also, or MASH cirrhosis nowadays, is also a common entity with our diabetic patient. And a simple platelet count can give us an idea, with of course low hemoglobin as well, can give us an idea that there is a liver disease which is developing in this patient. So apart from the cardiac and the nephro problems, even the liver diseases can be picked up by simple hemogram.
It's very important. Thank you, ma'am. And Dr. Chavan, a message for you from Professor Manisha Sahai, who is head of department nephrology at Osman. She says more than a decade ago, we conceptualized rubro-metabolic syndrome. Rubro means red, rubber. So rubro-metabolic syndrome means the link between anemia and metabolic syndrome. So thanks for highlighting all this. So we understand that when we are looking at investigations, it's of course you should be aware of the latest things, maybe NT-proBNP, maybe troponin from the cardiology perspective, or all the various hormones that we are fond of doing in endocrinology. But we shouldn't neglect the simple thing. And rubro-metabolic syndrome puts this into perspective. And Dr. Darshana, when the hemoglobin is low, then does that impact our reading of HbA1c? In simple words, and again, our audience, our friends today are physicians from across the country. In CKD, in severe anemia, in hemoglobinopathy, what should I be aware of? Should I trust the HbA1c report blindly, or should I kind of ask a few more questions before trusting it?
So hemoglobin is actually a protein. Heme is a protein part. So if there is a nutritional deficiency, like there is a protein deficiency, if there is iron deficiency, if there is hemoglobinopathy, and if there is CKD also, because there is change in the RBC turnover in these patients because of the suppression of the erythropoiesis. So that is the main reason why it will affect the HbA1c level in all these conditions. So in these situations, we should be also doing some other markers which will help us to get to the glycemic control of the patient. Like glycated hemoglobins are one. Then we can use a CGM for glycemic variability, and of course the sugar readings like the fasting and post lunch blood glucose level taken at different point of time can also help us to reach to the actual glycemic control of the patient, and not completely relying on the HbA1c, though HbA1c remains one of the important aspect nowadays for the glycemic control of the patient.
Thanks. So just be aware, and especially in people with CKD, for example, and then if you work in a part of the country where hemoglobinopathies are quite common, for example, Eastern India, for example, Northwest India, then if you are confused, there would be no harm in getting an HPLC electrophoresis done, so that you are aware that if there is a hemoglobin. Dr. Chaman, let's come back to the albuminuria part, the microalbuminuria. When I was a student, we used to do 24-hour collection. My thesis was on enalapril versus ramipril, impact on 24-hour urine. And as part of the thesis, I had to check 24-hour urine 3 times, to make sure, that is before starting the ACE inhibitor and then after. And it wouldn't be a surprise that half of my patients went lama because they were not willing to give 72 hours worth of urine. So what is it now? Do we do point of care testing? And how do we read these numbers? Microalbumin, UACR. Can you make UACR a bit simple for us to understand?
Sir, first of all, what you said about taking the time, the 24 hours urine protein test is definitely, I will say, gold standard to estimate the proteinuria, albuminuria, no doubt about that, and it will remain the gold standard. However, as you said, it is cumbersome, it is time consuming, and you need lot of complaint from the patient, and it is very difficult to use this particular test, 24 hours urine protein, for monitoring purpose. You can't subject the patient to do this test every month while coming for the follow. So what we are preparing now for monitoring purpose, to monitor treatment, as you said, NT-proBNP was your dissertation topic, sir. So what we prepare is the urine spot protein creatine ratio or urine spot albumin creatine ratio. So this test needs hardly 5 to 7 ml of urine spot sample taken any time in the day, and it is reported within 4 to 5 hours. And if it is lab in peripheral, 6 to 8 hours. And the figure it gives as a result, it usually matches with the 24 hours urine albumin excretion. So this test is very useful for all of us to monitor the treatment. Okay, first time when the patient is admitted, or first time patient walks into OPD and we want correct estimation, absolutely correct estimation of the proteinuria or albuminuria, we can definitely go for the 24 hours urinary protein albumin estimation. But I will suggest that we can now use urine spot protein creatine ratio or urine albumin creatine ratio, some people call as microalbumin creatine ratio, okay, for the monitoring purpose. So that is okay, sir, and that is what we are using nowadays, sir. And urine ACR, sir, as we are all aware, Patil sir is a cardiologist, Darshana ma'am is an endocrinologist, and you yourself, sir, is a very senior endocrinologist. Albuminuria is very, very critical thing. The presence of albuminuria denotes that there will be starting initiation first state of chronic kidney disease setting in a patient. So it is very important we should detect the albuminuria as early as possible. That is the time when we can do some changes in the patient's treatment to reverse the albuminuria. Once it goes into overt proteinuria, then it becomes very difficult task. It becomes a progressive disease, sir.
So, thanks, Dr. Pankaj. We are talking of a urine test. But now, when you were in hostel, we are told that you could predict the future of your classmates. You could tell who is going to lose her heart to whom. Now you are an interventional cardiologist. Now also you can predict the future. When you do an angiography, for example, in your heart, you know what the prognosis is going to be for a patient. But is this necessary that you have to do an angiography to be able to predict somebody's cardiac future? Can you predict the future using UACR?
Yes, definitely. It's not always like you have to go for angiography. Definitely, UACR, as discussed, as it is important in nephrology and other perspective, other specialty, it is equally important in cardiology point of view also. We do advise the test of UACR and at least urine routine microscopy in these patients, and we do follow up with the proteinuria part in these patients, especially those who are known heart failure patients, those who are on diuretics, those who are known diabetic patients, and definitely the proteinuria part, if at all if it is there, then we go for the quantitative measurement of the proteinuria in these patients, and we take help of nephrologists in these patients also. And UACR, as definitely, if there is a proteinuria in these sorts of patient, then there carries negative or poor prognostic factor in the heart patient, especially the heart failure patients. We can see in as the UACR as deranged, there can be a nephropathy, and ultimately you can see there is a hypoalbumin also. So these two are both the poor prognostic factor for the heart failure patients, and ultimately, if you see at the tissue level, it can harm you by provoking certain oxidative damages to the endothelium, and this will cause the inflammatory cascade and ultimately lead to the prothrombotic events like MI and stroke. So definitely USAR is the baseline and very simple measures. If not at all, at least a urine routine microscopy can be helpful, and this can be a simple measure to protect the heart above people away.
And UACR actually is point of care now, so it's very easy, and even the cost doesn't increase too much, so you can get it done immediately. And Dr. Darshana, what Dr. Pankaj said, let us just try to translate that for the patient. So I struggle, at least now it's nearly 3 decades now in endocrinology, but I still struggle to motivate my patients. When I tell them that your creatinine has gone up from 1.4 to 1.5 or 1.6, they laugh at me. They say, sir, so what? But the moment we show them a blood urea, 41 going to 48, then they wake up. But when we show them the UACR going from 30 to 70, the bigger the number, the more motivated they are. And what Dr. Pankaj said, can we translate that into a motivational tool in medical practice, in metabolic practice? Like you get a big UACR number, you tell the patient your blood vessels are leaking. That is what Dr. Patil said. The endothelium is leaking. It's leaking not only in the kidney, but also in the brain and the heart and everywhere. So, your comment, ma'am, in the general medicine OPD, metabolic OPC, how do we use UACR?
So nowadays, what patients I get, I think they come with the report and they're already panicked that it is 31 or 32. So I think the perspective of the patient is also changing, and it is going more to the preventive medicine now, because at this stage, as Dr. Chavan has already mentioned, that we can reverse things and we will avoid, progression of this CKD and CVD. As far as USCR is concerned, I think we can combine it with the NT-proBNP also, and then can show them that your heart is also at risk, because I think heart has more importance. Of course, for us, every organ is important, but for the general people, I think they are more worried about this heart attack, paralysis, and heart attack is very, very important for them. So if we combine that with NT-proBNP, and then we can show that both the organs are at risk together, then they will be definitely more motivated to a for the glycemic control, and two for they will be more motivated to go for the organ protective treatments like SGLT2 inhibitors and GLP-1 analogs, for which a lot of patients hesitate because of the side effect profile, or for the cost per se also. But if we tell them that these agents will be helping them reverse whatever the damage has happened, and prevent the further damage, and we can prevent the bigger damage, so they can get more motivated.
Very well said, madam. So if we tell our patients that we are giving you drugs which will keep your heart and your kidneys young, youthful, and you say it with a smile, then they listen. They actually agree.
Yeah.
Dr. Pankaj, these two tests, again, point of care, troponin T, troponin I, BNP, NT-proBNP. Could you just talk about what you do in your emergency room, why you do, what are these tests, and how do you interpret them? And again, our question is from a general practice perspective. Somebody comes to me in the evening with breathlessness or with vague uneasiness. The patient is not even able to verbalize what she has, but it's that I'm not comfortable. Then what will NT-proBNP do for me as a physician? How will it help me? What will troponin T do?
When a patient comes to an emergency department with the feeling of suffocation, breathlessness, and some chest discomfort, then definitely these two bedside tests are very, very important, like troponin T and NT-proBNP. First of all, if you want to rule out whether the patient belongs to any ACS, that is acute coronary syndrome, by ruling out troponin test at the bedside. And if at all, if it is not there, then definitely to rule out the cause of breathlessness, the simple bedside test of NT-proBNP is very, very helpful. It's a simple method to rule out acute heart failure condition at that time. If it is negative, then there are less chances of that patient being a patient of heart failure. You have to search out for the other causes of breathlessness in that patient. And accordingly, if it is significantly positive, then you have to start the treatment in that line of management. Ultimately, then we have to go for echocardiography. We have to question whether the patient belongs to heart failure with reduced ejection fraction category or not. And NT-proBNP, if you see, sir, it's actually rather than a one-time test, you can tell it as a series of tests. If you can, is it positive at the first time, definitely it can help you out in judging your therapy over a period of time. And after that, you can call that patient after 2 to 3 weeks or 4 weeks, and you can do the NT-proBNP. If it is in a decreasing trend, then you can say that our therapy is going properly, and the diuretic and all the more killers are going properly in these patients. And definitely, these two tests at bedside are very, very helpful. NT-proBNP is more crucial in heart failure patients, and the trend of this NT-proBNP over a period of time is very, very important. As if the NT-proBNP is on a higher side and the trajectory is on the higher side, then this patient carries a very high mortality and morbidity over a period of time.
And now in diabetes, both in US as well as in India, NT-proBNP is approved as an annual test for screening asymptomatic patients with type 2 diabetes. So if you have a person with type 2 diabetes, ideally every year that person should get an NT-proBNP done. It is more than 125 picogram per ml. Then we refer to go. Dr. Chavan, NT-proBNP, there is such a wide range. Do we read it the same way in people with CKD as we do in people without CKD? How accurate is NT-proBNP in severe kidney disease?
Sir, actually, NT-proBNP, the clearance of NT-proBNP in patients of CKD, that is reduced GFR, the clearance decreases. So, if you estimate the level of NT-proBNP in a patient with kidney disease, CKD patients with high creatinine, that is low GFR, the value will be elevated as compared to the normal adults. Okay, so the value in this patient, in these patients, the NT-proBNP, we should understand the value will be high as compared to the normal healthy adults. So we should interpret it carefully in CKD patient. It does show that there is congestion, there is increased load on the increased stress on the myocardium. However, it high on the baselines.
So the blood volume is increased. That is what NT-proBNP tells us. It tells us there is a stretch on the ventricular walls.
Yes.
But in CKD, there will be false elevation. And in obesity, there will be false low. So that is an easy way of remembering. In the kidney, you go up, and in obesity, you come down. So the cardiologist should also be aware of that. If you have a very obese person living with morbid obesity, and the NT-proBNP you have done for the first time, it's not so high. That doesn't mean the person does not have heart failure. So then the cardiologist will do an echo and will do other tests as well. So you are on the side of caution. Similarly, if somebody comes in with CKG stage 4 or 5 and you've got one high value, that doesn't mean that you label as heart failure immediately. It might be just simple fluid overload.
Yes.
So all these nuances are coming in. Dr. Darshana, like we began with urine routine, microalbumin, UHCR, and hemoglobin. Along with hemoglobin or iron, another mineral that we have is calcium. So let's ask all our experts one by one. First, Dr. Darshana. The question is, Madam, can you tell us about calcium, vitamin D? What is normal? What are the common diseases that you see? Then a question for Dr. Pankaj will be, the patient comes back from the cardiologist and the patient says, Sir, मैंने CT angio कराया, मेरे तो vessels में calcium जम गया है. I've got calcium stuck in my arteries. And it's all your fault because you and Dr. Darshana and the physician, they gave me vitamin D and calcium to eat for the last 6 years. And it's because of you that all the calcium is stuck in my arteries. How do we handle that, sir? And then Dr. Chivan, the last question will be to you. In kidney disease, of course, nephrology is always the most complicated. What do we do if there is low calcium, high phosphorus? And are there different rules for the left kidney and right kidney? So Dr. Thakur first, madam.
So, sir, simple, I think hypocalcemia and hypercalcemia are the two things which we deal. Hypocalcemia mostly because of the vitamin D deficiency, which is very commonly seen in our population, and that is also associated with cardiac morbidity in certain studies which have been seen in diabetic patients. So for these patients, I give vitamin D and calcium supplementation. Most of the patients who are vitamin D deficient are also calcium deficient in our population, so they need to be given calcium as well. Now, as far as the high calcium is concerned, there are different causes of hypercalcemia. So, in order to differentiate between different causes, we do the PTH level, and if either it can be a PTH dependent or a PTH independent hypercalcemia. Now, in all the situations with hypercalcemia, there can be calcifications in the vessels, and that can cause the increase the cardiac morbidity. One of the most common causes of hypercalcemia which we encounter is PTH dependent, which is primary hyperparathyroidism, and in that situation we localize the cause or the parathyroid adenoma, and then we decide whether to treat it surgically or to observe. So there are certain indication in asymptomatic. If the patient is symptomatic, we go ahead and get the adenoma out surgically. So in both the situation, we have to look into the symptoms of the patient and the clinical presentation. And hypercalcemia also increases the cardiovascular morbidity, and therefore it needs to be addressed in each patient.
From our epics, from the Indian epics, we have many examples of metabolic bone disease. So, for example, Manthara, who was the vet nurse for Lord Ram, she's shown to have osteoporosis. She would have had an osteoporotic fracture. But if you look at the positive points, so let's ask everyone, the Konark temple, what is the history of the Konark temple? Who is it who was disfigured with leprosy? Who went and prayed at the Chandrabhaga river for 12 years? So it was Mycobacterium leprae, very slow growing, very slow to treat. But finally, after 12 years, that person got cured of leprosy. And then the Konark temple was made there to worship sun. We worship the sunlight. So that's a question for everyone. And if anyone is watching from Odisha, no excuses if you're not able to answer correctly. Another example from our epics is the Vajra of Indra. So Vajra means weapon. So the sage Dadiji, and there are many examples, different stories of this, but sage Dadiji is an example of positive endocrine health or positive osteocrine health. His ashram is thought to have been in Sipakot district of Uttar Pradesh. So it is said that he received boons from Lord Shiva, and one of the boons was indestructible bones. So his bones were so strong that they couldn't be destroyed. The Devas and the Asuras were fighting each other. The Devas got in trouble, so they realized that they need an indestructible weapon or Vajra, and they reached Dadiji. He sacrificed himself, gave them his spine, and then they fashioned the Vajra, or Indra's Vajra was fashioned out of Dadiji's spine, and then they won the battle. So these are examples of good health, good bone health, and you might want to use these to motivate your patients to take calcium. Whether you're motivating a child to drink more milk, or whether you're motivating a perimenopausal lady to, adhere to her calcium and vitamin D. But Dr. Pankaj, this opposite problem, like we said, patient is very happy with us. We send them to the cardiologist. Everybody is happy with life. Then the cardiologist brings in an angle of calcium. You've got calcium in your bones. And then our OPTs suddenly become very unhappy. So is the serum calcium the same as coronary calcium? And what are the nice ways? How do I explain a CT angio report to my patient?
Basically, CT angio is being done in two parts. Some do only calcium score and some do a complete CT angiogram. The CT calcium score is just a screening tool which we use in the patients who are at low risk for the coronary artery diseases. So calcium score is being categorized according to the scores over there. So high calcium score is not like that there are blockages in that patients, but they are prone for the blockages in future. So a younger patient within 40s or 30s having a calcium score of higher side definitely is not a normal. But if you go for a elderly patients after 60, definitely there will be some calcium deposition over the arteries, and certain endocrine abnormalities like hyperthyroidism and certain things diseases can aggravate these calcium deposition in the arteries as per the not only coronaries but the peripheral arteries also, and you can see in the carotids and other aortic knuckle also. So it is not directly related to your serum calcium level also, but definitely there are certain people who are more prone for the calcium deposition in the coronaries, which may have certain coronary artery disease in future. But definitely I have not seen any direct to direct correlation with the serum calcium levels in this coronary extensive coronary calcification. When we correlate with these calcium levels of these patients, these calcium levels are on lower side. I think I can see there are vitamin D deficiency in this patient especially, but they have an extensive calcium deposition in the coronaries, and we generally do, give vitamin D supplementation for the low vitamin levels in vitamin D levels in this patient. So definitely there is no as a direct to direct correlation. I don't know about any studies being conducted with the serum calcium levels and the extensive coronary calcification in these people. But definitely in my practice till now, I have not seen any correlation between these two things.
It is nice if we are able to counsel our patients properly, so that because now there is a lot of crosstalk. Like between us, we are all speaking, but our patients go and speak to multiple doctors. So one way I have found, Dr. Darshana, which might help you and which might help others, is that you tell them that, yeah, you are low in vitamin D, and that is why the calcium has gone to the wrong place. We wanted to send your calcium to the bones, but unfortunately it has gone to the coronary arteries. If we give you adequate vitamin D, then it will get transferred from there to the bone, so don't worry. That is one way. The other way we tell them is just like you have muscles, you have biceps and triceps, so that everybody understands. Your heart is also a muscle, which is scientifically true. So if you take more adequate vitamin D and calcium, you will be able to exercise better and your heart pumping will become better. So the heart muscle will improve. But Dr. Chavan, again, Goldilocks, vitamin D in chronic kidney disease, calcium in chronic kidney disease. And when we were students, calcium phosphate ratio used to be a big thing. Is that still a big thing in modern nephrology practice, or do you not bother about calcium phosphate?
And no, sir, we do bother about calcium phosphate level. The kidneys, as we are all aware, it produces the active form vitamin D, and that is very much important to maintain the serum calcium level. And as the kidney disease progresses, CKD worsens, the production of this active form of vitamin D, vitamin D3, decreases, and then hypocalcemia sets in that stimulates the parathermal release by pineal gland, and all these cascade, including elevated level of FGF23, it leads to hypocalcemia, hyperphosphatemia, decreased vitamin D level in the blood. Now, this calcium and phosphorus product is a dangerous because it gets deposited in the vessel walls as well as extremities of the vessel, first capillaries, sir, where it can, the interesting is calciphylaxis, it can, this thing, and sir, this decreased serum calcium level leads to, this whole scenario is labeled as CKD-MBD, CKD venereal cone disease, sir. And we need to maintain the calcium level in the normal level by giving calcium supplements and vitamin D supplements, and decrease the phosphorus by restricting the dietary intake of the phosphorus. since the GFR has gone down in the CKD patients, it is difficult to make the kidneys to excrete the phosphorus like normal adults. But we can restrict the phosphorus level in the diet. We can increase the calcium supplementation and vitamin D supplementation, so that calcium and vitamin D level is maintained in the normal range, as well as parathormone level should be maintained in the normal range. That is difficult, but still we can try our best. Now, sir, increasing the calcium level to the high level unnecessarily is also not indicated, because it will increase the calcium phosphorus product, as well as sir, this hypercalcemia, as well as more than required vitamin D supplementation may lead to another form of CKD MBD, which is a dynamic bone disease. That is also a dangerous thing in the CKD patients. So we should maintain the normal range of calcium, phosphorus, and vitamin D in these patients. Yes,
Yeah,
sir.
and it's really, really important. Dr. Darshana, in your practice, do you think that we are all guilty of ignoring high phosphate and high and low phosphate levels? So in a busy OPD, like you said, patients come with 15-page sort of big files of their reports. So you say, yeah, the HbA1c is important because I know how to interpret. And then maybe the hemoglobin is also important because I know how to interpret. But phosphate array, it doesn't matter, that it's a lab error. So do you think we are guilty of that? And what message would you like to give us? When do we wake up if we see a low phosphate and or a high phosphate? And what should we do?
So I think yes, phosphorus is a little neglected one for us. Most of the time, low phosphate is associated with vitamin D deficiency. Low phosphate, low calcium, with low vitamin D. So we try to manage it with giving vitamin D to the patient. Next time देखेंगे 3 months down the line, 6 months down the line, we repeat. But if there is persistently low phosphorus and with a upper normal, high normal calcium or a higher calcium, then we know that this is hyperpara, possibly a asymptomatic hyperpara, but that needs a complete evaluation. Now, as far as the high phosphorus is concerned, yes, I think we label it a lot of time to a lab error, and we try to repeat it a lot of times before we evaluate. Evaluation being a little tedious. If the creatinine is normal, then high phosphorus level, evaluating high phosphorus level, I think is a little tedious. So we try to label it lab error and then just move on, because we have a lot of other problems to solve for them, like diabetes, kidney disease, diabetic kidney disease, diabetic liver disease. But yes, if it is persistently high, I think that warrants some attention to it.
What I can say to everyone, to all of us, and I would be the first one to plead guilty, to make mistakes. Yeah, Dr. Chwan wanted to say something. Yeah. So basically, if let us say you see an abnormal report, you talk about diet. If the phosphate is low, you encourage non-veg food. If the person is able to take, you encourage dairy foods, and you point out to the patient. You say, yes, I have noted that phosphate of 2.8. Let us improve your diet. Let us give you calcium, vitamin D. Do not get the test done again after 6 weeks. That is a strong message that we make. At least the patient will remember to get the test done after 6 weeks. And then you follow up again. Suppose the phosphate is high. Again, you talk about dietary restriction, maybe reduce alcohol, reduce purines. But then you also look at the skeletal health and renal health. If there is any other red flag for renal health, maybe CKD stage 3A, that is a red flag. No harm in getting a nephro consultation. If there is any skeletal issue, patient has got symptoms of metabolic bone disease, or patient has got signs, or maybe the X-ray shows even spondylolisthesis, even something simple like that, then again you say that yes, this is an issue, you need skeletal follow-up as well. So this is the least that we can do. And if you see the same abnormality coming in twice, like low phosphate, then the third time either you evaluate yourself or you send to someone else to evaluate, because this is a mistake that we make very frequently. Dr. Chwan, Dr. Pankaj, you spoke about organoprotective therapy. So let's move on to that. Dr. Chwan, do you feel that the kidneys are neglected? Dr. Darshana said everybody bothers about the heart, and the kidneys are discriminated against, and poor little kidney doctors are also discriminated against. Do you sometimes feel like that? And you are muted, so that shows the level of discrimination.
Sir, what you said is the right thing, sir, because as we move from the metro cities to periphery, tier 2 city, tier 3 cities, we notice that patients forget about phosphorus, even rising creatine also patients are not aware that they have kidney problem. They need to pay attention to their kidneys. When we ask them in this thing, in the follow-up that "Hey, तुम्हारा creatine तो high है, your creatine is high." They say, so what, sir? I don't have any problems. Why I should be bothered about this thing, high creatinine? And even in the CKD patients, when we advise them calcium, phosphorus, uh, nothing more than the uric acid. They are very much fond of uric acid. I don't know why so much this thing about uric acid, but people will do the uric acid, but not the phosphorus bit. Okay, and definitely it is very much neglected overall. The patients, I think one of the reasons is that they do not get much symptoms. Like in the heart is very much favored because chest pain means everybody is afraid. And I am very much sure Patil sir must be getting lot of patients who actually don't have any ailment related to direct to the heart. Maybe it is lungs or musculoskeletal pain, but they are willing to get the TMT, 2D, or even angiography also. They will they will proudly tell that do हमारा एंजियोग्राफी कर दो, लेकिन देखो क्या है. But if I tell them that you need to do calcium, phosphorus, vitamin D, you check the urine ACR ratio, we don't have any problem. Why should do it? Definitely, sir. As far as nephrology is concerned, we come in the picture very late.
One hypothesis that we have is that this is a Bollywood discrimination. So, Dr. Pankaj, see the Bollywood songs. There are so many songs that revolve around the heart. Happy songs, heartbreak songs, sad songs, future songs, past tense songs of the heart. But hardly any songs that revolve around the kidney. But then Bhojpuri music, now Bhojpuri is a language from Uttar Pradesh and from Bihar. Bhojpuri music decided not to discriminate. So they have this beautiful song where the boy is singing to his girlfriend. He says, either you give me your heart, but if you don't want to give me, doesn't matter, then you just give me your kidney. I'll sell your kidneys and become a crorepati. So that is a voice for equality. Now, Dr. Chauhan, suddenly do you feel happy about Bhojpuri music and how they are sort of fighting for nephrology rights?
Sure, sir. I have not come up with this song, but I will be very happy. I want it to be in all languages, all the regions in India.
A great idea. And at the Endocrine Society in India, yeah, carry on, Dr.
Sir,
Chauhan.
kidney, but sir, one problem with the kidney is that whenever people think of kidney taking out or giving kidney, so they have some different misconceptions about the kidney. Kidney nikal liya. Even though people have done the nephrectomy for kidney which is chronically pyelonephritic kidney, but after 5 years the person will say मेरा kidney निकाल लिया डॉक्टर ने, उसको मालूम नहीं क्या किया उसका, but my kidney was removed. It is again because of the Bollywood and what's the curiosity, sir.
And while giving hearts and taking hearts is kind of common, you don't have to lose your heart also in colloquial language, but for kidney, people get upset. In the Endocrine Society of India, we have an annual program called Colors of India, where all the endocrinologists dance and sing and have fun. So perhaps, Dr. Darshana, next time we should have a theme around the kidneys and heart and how the hormones can keep them happy.
Yeah. Absolutely, sir.
But speaking of organoprotective medicine, before we complete, ma'am, what are the newer drugs that are available now, oral drugs that we can use for diabetes management, and where we can confidently tell your patient that, sir, madam, not only are these safe for your kidneys and heart, they will also protect your kidneys and heart, they will keep them younger. Do we have any oral drugs like this?
So SGLT2 inhibitors are organoprotective for any patient, diabetic patient with cardiovascular risk. We are supposed to go for SGLT2 inhibitors, and also for CKD patients with proteinuria, or the patients with proteinuria, we prefer SGLT2 inhibitors. The second class of drug is GLP-1 analogs. We have oral GLP-1 analogs which are available, so that these medicines can be preferred for the organ protection part. And injectable also we have injectable GLP-1 and GLP-1 GIP dual analogs are available, which also provide organ protection. So these are the medicines which are available, and we should be giving the benefit of these medicines, because now the glucocentric we used to be glucocentric previously. Now it is shifting to the organocentric or organoprotective diabetic management now. So not only the glycemic control is important, but long-term organ protection has also become a very important aspect of diabetic management nowadays.
And Dr. Pankaj, in the cardiology OPD, in the medicine OPD, somebody comes in, someone who has established ASCVD or is at high risk of ASCVD. And that, I think, would be the vast majority of all Indian adults. Virtually everyone is at high risk of ASCVD these days. The patient has diabetes, doesn't have diabetes. In all these scenarios, what is the role of dapagliflozin? How frequently do you use it now in your clinic?
Irrespective of ASCVD, dapagliflozin being used very commonly in patients of heart failure, especially patients with a reduced ejection fraction category. We use dapagliflozin as one of the pillars in the management of heart failure. So there are many studies and landmark studies of dapagliflozin in the patients with non-diabetic also, in which the dapagliflozin was proved to be beneficial in these sorts of patients. So definitely, SGLT2 inhibitors like dapagliflozin is very, very helpful in non-diabetic patients also, like equally in diabetic patients, as a one of the pillar in the management of heart failure.
And any challenges that you encounter as a cardiologist, has the patient ever told you that, sir, this is an anti-diabetic drug, or has your colleague ever said something to you that this is only my right, I am the endocrinologist, I am the metabolic physician, I will prescribe, who is the cardiologist, right? Have you ever faced any challenges?
And the most common problem I have faced that I have consulted the patient in my OPD clinic, right? This is the medicine for use for heart failure. But sometimes what happens at the pharmacy level, these patients being told that this is a diabetic medicine and you are non-diabetic, why are you taking these medicines? So sometimes this happens, and I think out of 10, 2 or 3 are the people we do stop this medicine as per the conversation with the pharmacist. And when they come up with for follow-up, we can see these patients are not taking the dapagliflozin or SGLT2 inhibitor in any form. So this is the most common problem which I have faced at this level, that this is a diabetic medicine being told by the pharmacist. But again, you have to counsel, because this is one of the crucial part of the treatment in the heart failure. So definitely we can't skip that part in these patients.
This problem I also faced along with my colleague. His name is Dr. Kamal Kishore. He's a cardiologist. He takes care of my blood pressure and cholesterol, and he also takes care of my patients. So we found that both of us were facing the same problem. So what we just hit upon on the side, you just write for vascular health, for heart health, something. And then some places we write for improving ejection fraction on the side. Then whether the pharmacist understands what ejection fraction or not is, that is separate matter. But he feels, yes, the doctor has spent extra time, then he gives it quietly, yes, this is for your heart. So that is something we can do in case we feel that the patient is not very cooperative or is not understanding what we are trying. And Dr. Chavan, dapagliflozin in the nephrology clinic, how important is this? And how has your practice changed? What is the threshold of EGFR now until which you use DAPA?
So dapagliflozin has come as a big way in nephrology. Okay, and I will say now people in nephrology are saying that after the introduction of the drug RAS inhibitors, that is our ACE inhibitors and is ARBs like telmisartan. Now this is a second drug which is a path-breaking drug, I will say, that is SGLT2 inhibitors, dapagliflozin and pagliflozin. These two drugs now almost in every patient of CKD, irrespective of diabetes, they are indicated. Especially proteinuric CKD, they are very, very important. After the introduction of ACE inhibitor or ARB, the next drug we should introduce in all CKD patients, irrespective of the presence of diabetes, type 2 diabetes or diabetes mellitus, the dapagliflozin is a drug of choice, no doubt about that. It increases it improves the morbidity and long-term mortality. It retards the progression of CKD. So dapagliflozin is a drug of choice now, sir. Even some chronic glomerulonephritis like IgA nephropathy, sir. Okay, IgA nephropathy, dapagliflozin is a drug of choice nowadays, sir. We have to prescribe this drug, sir, dapagliflozin. So irrespective of the diabetes mellitus, sir, we should prescribe this dapagliflozin. And as far as GFR is concerned, sir, initially there were some reservations that below 45 GFR we should not give, but now it has come down to almost 20-25. Empagliflozin is 20, dapagliflozin is 25, and even sir, as such there is not contraindication of dapagliflozin in a patient on hemodialysis. Only thing that the benefit is not much. That is what the trials and research shows, that the benefit may not be suppose a patient is GFR is 30, 35, 40, 45. The benefit we tend to get from using dapagliflozin in these patients, that much benefit we will not get in the patient on the hemodialysis. But definitely dapagliflozin is nowadays it's one of the important and like a kind of mandatory drug in this patient of CKD.
And I suddenly realized, Dr. Chavan, while we were all discussing, that all these biomarkers that we spoke about, dapagliflozin actually improves hemoglobin, as opposed to pioglitazone, which may reduce because of dilutional effect. It also improves albuminuria. It will improve the NT-proBNP, and it will improve NT-proBNP. And it will have no negative effect on calcium phosphate. It doesn't impact the bone negatively. So one drug for so many, purposes. So that is something very nice, which I realized just now. It's been 1 hour, Dr. Pankaj, Dr. Darshana, Dr. Nainesh, since we began speaking with each other, and we didn't even realize the time. But I'd like to thank all of you and everyone who is logged in with us from across the country. So perhaps before we conclude, maybe we can have take-home messages from everyone. Dr. Nainesh, our topic for today was the various biomarkers and how they impact our metabolic practice. So final take-home from you, sir.
Sir, from my side, sir, detect the albuminuria early, and if the look for the trend of the albuminuria, if it is rising, we should act fast and promptly to decrease the albuminuria in patients, so that CKD progression is slowed. That is one thing. Second thing is, we should introduce AT2 inhibitor, and if possible, non-steroidal melanocortin receptor antagonist, that is the newer drug is finerenone. And dapagliflozin we should prescribe in these patients of CKD, especially potent CKD. Then we should interpret the result of NT-proBNP in the CKD patients, because the level is little higher side. But we should use, as Pati sir said, we should use the trend of NT-proBNP in this patient to assess the myocardial muscle stretch and volume assessment, sir. So these are the takeaway message. And sir, of course, calcium, phosphorus, vitamin D level we should try to maintain the normal level, normal range, to prevent the vascular calcification and further complications of CKD, MBD, mineral bone disease in these patients, sir.
Especially if you have a patient with the renal impairment, do not neglect these metabolites. All the minerals and the vitamins and electrolytes, all are equally important. Dr. Pankaj, a question coming your way. We need your take home as well. So this is Dr. Dipesh. He is a urologist in Jaipur, and he is married to Dr. Ankita Aneja. She's an endocrinologist trained at Safdurjung. So he says, sir, how do I keep my heart safe?
Okay, how do I keep my heart safe?
That's the question for you.
Yeah, so basically this is out of this context, but definitely it's a very simple question, nothing related to the markers over here. It's a healthy lifestyle, including your diet, exercise, adopting a proper WHO guidelines of exercise. All these things included with a stressless life definitely will help out in keeping your heart safe. And do annual checkups annually, definitely. I do check my personal parameters annually. All the blood parameters are the markers along with ECGs and echoes. I personally, I'm a runner, so I do screen myself every yearly. So there's nothing as such, any rocket science behind that. Just simple things which we advise the patients. We have to follow this. Definitely, you will have a very healthy and beating heart.
Thank you. So practice what you preach, and this is a great message for all of us. Dr. Darshana, it's hormones which talk to each other. So it's hormones which keep the entire body together. Even if you look at the nervous system, that is also based on neurotransmitters, and the vagal tone, the adrenergic hormones, they are also hormones. So would you like to put everything together for us, madam, and for everyone who's listening to us?
So I think most of the disorders are nowadays linked to the lifestyle. So if we follow a good lifestyle, I think most of the hormones and the neurotransmitters will fall into place. So a good sleep is very important, 7 to 8 hours of sleep, because most of our hormonal rhythms are diurnal and they are connected to our sleep cycle. So a good 7 to 8 hours of sleep, a good exercise around 45 minutes to 1 hour of exercise at least 5 days a week, and balanced diet. I think they are the crux of management of any of the lifestyle disorder. As far as the diabetes is concerned, glycemic control is definitely important, and that can be assessed with different markers as we have discussed today. And the markers for the complications like albuminuria, NT-proBNP, and the other ECG2D echo. So we need to screen all of them to pick the disorder in the subclinical or the complication in the subclinical phase, so that we can halt the progression. We can make more awareness of the patient so that the patient becomes more acceptable to the diagnosis, and then can be more, he will be more serious about managing diabetes, because a lot of time diabetes will 50% of the time diabetic patients will not have any symptoms, and then they will say आप मेरा sugar तो 300 रहता है, I don't feel anything, then why I should be controlling the sugars. But if we can show them that the NT-proBNP is increasing, there is albuminuria which is happening, so this diabetes is killing you from inside like a mite or termite. So we can make them more acceptable to the diagnosis and more acceptable to the treatment. Now, as we have the organ protective treatment modalities available in the form of SGLT2 inhibitor and the GLP-1 analogs, we can offer them these modalities of treatment and halt the progression of the organ and the organ damage as well. And in a good number of patients who are young or middle-aged, obese patients, we see the pharmacological remission kind of a situation also with the weight loss which is happening with these medications. So all in all, we can manage diabetes well if we utilize all these markers timely.
Very well said, and I'd like to thank all of you. Basically, what we learn is that some of the simpler things in practice or in life are what we miss, whether it's a hemoglobin or a urine microalbumin estimation, whether it's talking about lifestyle, diet, and exercise, or whether it's talking about organ protective, organ supportive drugs like dapagliflozin. But if you're able to share this with our patients, simple information, and we practice what we preach, then the healthcare acceptance, like Madam has said, the healthcare adherence, and the healthcare appreciation, appreciating what the physician is doing for the society, all these will go up. So we just need to talk to our patients in the right way, that we have drugs for you which will help protect your organs, which will prevent them from getting damaged, and which will promote a longer and a happier life. With this, we wish you all the best. Thank you, Dr. Nainesh. Thank you, Dr. Pankaj. Thank you, Dr. Darshana. Thanks, everyone, for being with us. Don't forget to tune in to our next episode of 4D as well. Detailed discussion and dialogue in Indian diabetes will continue. Jai Hind.
Thank you.